Well, thanks so much, Atul. That's a wonderful overview of what we think is going to be happening, and I think it's a high likelihood, but it's going to be a very complicated dynamic going forward. And I will show you a perspective that's important to all of us as healthcare consumers and policymakers, from the perspective of the partialists. My friends at the GME that accredit all of our training programs, they like to refer to folks like me as partialists and folks like these guys as comprehensivists. And I think that's sort of discriminatory, but I won't go too far into that.
Well, you're only partialist until somebody has a part that needs fixing. Right?
That's the point. And if I could please ask anybody who's eating lunch, who doesn't want to see a part of the human body on a slide, please look aside for just a moment. This slide I put in for really two reasons. One, if you look at the device right there that the surgeon's hand is holding, it's very interesting technology. It's a neuronavigation tool. It requires a lot of computer horsepower and a lot of advanced imaging to prepare for an operation. And that's to make sure that we, A, go to the correct side, and B, hit the target rather than something that should not be hit. And the second point is that this kind of operation, and certainly the kind of operation that Gabby Giffords received, cannot be done by alternate providers. And we're all grappling with who's going to be providing what aspects of care as we look to the future. But there are certain things that are going to be in the domain of technical surgeons. And in Congresswoman Giffords' situation, that requires 365, 24/7 coverage of a level 1 trauma facility by neurosurgeons, because nobody else can actually do that. I want to hit a few points today in a brief period of time, some of which Dr. Grover hit well. Increasing demand of surgical care, we believe that's a very high likelihood. The distribution and what I'll call maldistributions of surgeons in the United States, with maybe some thoughts about how to deal with that. Particular problems related to trauma coverage over broad areas of our country, and pediatric services, which also was alluded to, which are quite vulnerable as we look at the current and future environments. We have a graying problem in surgery. Fortunately, it's spared me, but many of my colleagues do seem to be aging. The neurosurgical pipeline problem that Atul alluded to, and that is how long it takes to make a decision which alters the workforce. You're talking about many years to actually have an impact. And then I'll reinforce some of the GME funding decisions that we as a society have to make and what the implications of those are. This slide actually relates to the demand or predicted demand for services as we go out to 2025. And as you see, the top three on that list are unexpected: vascular surgery, cardiology, and neurological surgery, and that relates to the aging public. We're going to have problems with stroke, with coronary disease. What about back disease, degenerative spine, one of the most common ailments of mankind? And as you can see, the dotted line here is the demand for comprehensivist services. And we're seeing it now. This is 2013 data. And if you look at the top on the total, these are physician office visits. In the last several years, that trend has been downward, less office practice. That ticked up in 2013 to some extent, but largely it was in the category that is in blue there, and that's specialty services. If you look at our seniors in this area here, a dramatic difference between specialty requirements and primary care requirements for our folks over 65. And for every demographic younger than that, primary care actually shrunk some during that year while the specialty requirements went up. Will that continue? We don't know. And wait times, I won't dwell on this, but if you look at this slide, you can see that for subspecialties, the wait times are really 3 weeks to 3 months. That doesn't mean you can't get in urgently to see a physician with an urgent problem, because that happens today or this hour. But for routine office practice, that's what you're looking at. We don't know the right number of neurosurgeons to supply services to this country. And there are several reasons for that. And one of them, our current numbers are 1 to 61,000. But what about a new disruptive technology coming online, a new condition that we can treat that we can't treat now? What about the loss of certain procedures that are proven to be invalid or replaced by a tablet, for example? There's a lot of unknowns here, and the distribution that I'll mention here really confounds us even more. This is a slide showing the prevalence of surgeons, or density of surgeons, per state. The white states that you'll see here, Oklahoma, Arkansas, Nevada, they have very few neurosurgeons. The District of Columbia, for example, has a very high density of surgeons, and a place like Texas is intermediate. This is an interesting way of looking at the distribution problem. The bottom line is that 25% of our population lives in a county without a neurosurgeon. 50% of our population lives in counties with only 15% of our neurosurgical workforce. It's a little better in general surgery, but still only 30%. And this just shows, this line I'm showing right there, this is the 25% with zero neurosurgical availability close at hand. This is a metric that's been used for a number of years to look at distribution. And if you look at all of our specialties, the primary care fields have really matched the distribution of patients in the country. And leadership is important. Neurosurgery leads the way in lack of evenness of distribution. And why is that? There's several reasons, but one of them I referred to earlier. High technology dependence, a lot of imaging, a lot of infrastructure personnel to allow us to care safely for patients with these problems. And also the other issue that the more you do, the better your results are. So many services are very focused into certain areas. This is a map of the United States that looks a little white when you look at it from afar. And the unfortunate thing is that each of those white counties has no neurosurgical coverage. So that's the distribution issue. What about trauma? Trauma is a very difficult problem, particularly in neurology and neurosurgery, because the time you have to intervene is often minutes. An epidural hematoma, if you're not able to get that blood clot out of the brain as it rapidly expands, within minutes the patient is dead. And that's why this slide is particularly alarming. The red dots that you see are level 1 trauma facilities, and look at the broad areas of the country that are underserved. And if you can find a blue dot up there, your eyes are pretty good. But the blue dots are pediatric level 1 and level 2 trauma facilities. So those are even substantially rarer. The graying problem. Highlighted in blue here are the percentages of surgeons across the disciplines that you can see across here that are over 55 years of age. So that's a substantial chunk of our workforce. And that's across the country. This is not a regional problem. The blue bar is for all surgeons, and subspecialty surgeons or partialists like me are the orange, and we're a little older than our cohort. It's even worse in the rural areas where the safety net is a little bit more fragile. We've got a workforce that is even older, with many specialties over 50 years of age as their median age group. For neurosurgery, 44% of our practitioners are over 55 years of age. So that means that we're looking at a little bit of a train wreck as we go forward as the boomers approach retirement. Are they going to be replaced by our pipeline under our current thought process? So what does our workforce look like? In 2013, we had a little over 3,700 boarded neurosurgeons that were in practice to cover over 5,700 hospitals, 1,600 of which require trauma coverage, and 1,000 of which are stroke centers, which means immediate type intervention, or the hope is lost for those patients. We are a society with more than 317 million people, and our aging population is going to have these problems. They're going to have cancer. They're going to have stroke. They're going to have degenerative brain disease like Parkinson's disease. What about our training and our pipeline? Dr. Grover alluded to the fact that we are slow learners, which I appreciate. We have 105 accredited programs, about 1,200 residents at this time, and about 160 complete trainings. It ticked up to 180 or so this year, but the length of training is a long time. And if you think about it from the start of medical school until certification, you're talking about 18 years of life. That is the pipeline to get people to be board certified practicing neurosurgeons. That's a very long time, and because of that, it's not like steering a fighter jet. This is more like steering the QE2 to try to miss an iceberg. Policy decisions require a lot of time to have an impact. It costs money. This is a breakdown in a program from Pennsylvania, but this data has been independently confirmed, looking at the cost to train a neurosurgeon. There are institutional costs, some of which are covered by CMS, by the direct and indirect payments referred to earlier, although there are a lot of these that are over the caps, meaning they're uncovered, and they have been shifted now to our individual departments. But you can see that, in fact, the cost to train a surgeon is $1.2 million over 7 years of time, which is a lot. What does our match look like? This is looking from 2009 down through the current year. The number is basically flat. This uptick may turn out to be a little bit of a trend. It may not. But we're basically matching 100% of our training programs. And graphically, this is what it looks like. I don't see anything in the in terms of trends, in terms of our applicants, and these are the ones in the other two that are accepted, matched and accepted into training programs. It's pretty flat, and that's re-emphasized in this slide here, showing neurosurgery over the last several years, and many other programs. General surgery, for example, is going up. Family medicine, fairly significantly up. But neurosurgery is clearly lagging in this way. Of the first-year residents by specialty, that tiny little dot over there is us, and primary care is enormous in terms of the infusion of talent. Only 83% of our surgeons take emergency calls, and that is going to be worsened as our boomers approach their final years in practice. Pediatric neurosurgery is really dangerous. 178 board-certified pediatric neurosurgeons, and within the next decade, 42% will retire, and only 6 people a year enter that fellowship training in pediatrics. We know from a surrogate of is there capacity, we see job postings, and we see a lot of them, which implies that their practices and hospitals are acquiring neurosurgeons aggressively. This is a very interesting and informative slide looking at medical school graduates, and this is where we are currently, and this is where we project, just based on the factors that Dr. Grover referred to, the number of medical school graduates is going to be going up with the creation of new schools, and are we going to be able to accommodate them? If we just continue doing what we're doing, you see that we do not meet that need. If we are flat to current, we don't meet it by a lot. And if we reduce by 1% per year the funding of GME, we are dipping into a very serious low, and at 24.5%, the numbers become daunting. And this is a graphic put out by the ACGME after with a number of surveys of designated institutional officials. And if you cut funding by 50%, as has been proposed by MedPAC and Simpson Bowles, that would result in dramatic loss of training positions in all of these black states, which are high-density population states in general. losing 33,000 graduate medical education training positions. A state like Texas, it's rapidly growing, 500,000 population added each year. In every specialty, Texas lags the rest of the country in physicians in each discipline. Look at neurosurgery, United States 1.46 doctors per 100,000, Texas 1.28, and those numbers prevail really through all specialties. So in Texas, to keep up with the population growth, we have to produce 2.5 to 3.5 doctors per day, and cuts to funding will exacerbate our current and subsequent physician shortage. We need to pass legislation to increase support for GME, and we will be short, as Atul showed, 65,000 specialists as well as 65,000 primary care doctors in the United States by 2025. And that we've got to do something about. For further information, and Katie Rico is in the audience here with us today, we will provide whatever you need to reinforce this information or provide you other things that you need. Thank you.